Okay.
Okay, thank you very much, and sorry for the inconvenience. Thank you for the invitation and the secret organizers. I want to talk a little bit around the discussion, and I want to start talking about this is a very, very big problem all over the world. And it's a pandemic problem in the world, the hip fracture, especially the intertrochanteric fracture in elderly people. So this is some percentage of, as you see in the United States, 22% of the population will be over 65 years old soon in 2050. 650 fractures per year in the United States, and the rest of the world is 4.5 million per year. So this is a really big problem. And here is a difference between the conference from Dr. Denari, the neck fracture, and the intertrochanteric fracture, and the solution is totally different. And I agree, in these cases you need to do a hip replacement probably because the vascularity of the head. But here you can do very different you can do different solutions. You can use different solutions. For me, the most important problem in the extracapsular fractures are more common in elderly people, and the bad quality of the bone led us to think about in different solutions. Sometimes this fracture produced by low energy trauma and not compromise the healing of the bone. So you are allowed to use probably different solutions and not a prosthesis, but you have some opportunities to use it. What is the goal of treatment? Return to the patient's previous activity level, and that's very important because the elderly people get in a depression, very high depression after a hip fracture, so that's the main problem for me. Initial management, resuscitation, take the x-rays, AP, the hip lateral view, and absolutely important pain management, treatment of the comorbidities, improving mechanical ventilatory thromboprophylaxis, and it's best do this operation in the first 24 hours. Sometimes you can use CT and MRI because uncertain diagnosis, patient with polytrauma, and it's very important to not bypass some fractures. You can see here the diaphyseal fracture, and if are concentrating the diaphyseal fracture, we can forget this fracture here of the neck. So it's very important to be very careful in the polytraumatic patients. The ideal treatment is achieve lower morbidity and mortality, best short-term result, and cost effectiveness. The gold standard in the intertrochanteric fracture is still the internal fixation, but in unstable fracture have more problems, and it's probably the situation then you need to use a total hip arthroplasty, and it's valid treatment and is a very good option right now. As we see here, this fracture, and we can have a solution of this problem with this bipolar prosthesis. Why arthroplasty? In unstable intertrochanteric fractures in elderly patients are associated with the high rates of mortality and morbidity. In elderly patients, fractures instability, combinations, and osteoporosis worsens the prognosis, and a high rate of general complication associated with internal fixation due to prolonged recovery time. You see here a lot of problem with the internal fixation. As you see here, or this is another case. Probably the first view, it's okay, it's stable, but over the time the cutout it's produced, and there's a lot of complication with this kind of prosthesis in elderly people with osteoporotic bone and unstable fracture. So that's probably the best probability to do hip replacement and have a very good solution and a fast recovery for the patients. The incidence of complications such as pulmonary embolism and deep thrombosis and pneumonia, it's very important, and if you can bring the patient to weight bearing faster and not prolong the best rest, is probably a good solution using an arthroplasty. In elderly patient, instability and osteoporosis result in a poor fixation that cannot tolerate immediate weight bearing. Mortality rate in the hospital ranges between 0.03 to 10.5, but all over the year goes up to 22%. So that's a very high level of the complications, and probably is the best situation to use hip prosthesis. The first person talking about use a hip prosthesis in Trochanteric fracture was Dr. Tronso in 1974, and he recommended that since that time to use probably the arthroplasty primarily in these patients with as a salvage procedure for a failed internal fixation, and use these kind of devices, calcar replacement, hemiarthroplasty, or tripolar cups. So this is two examples for that. It is arthrosis in this patient with cutting out osteosynthesis, and this is a very good solution for this patient using a prosthesis. And this is another case. You can use a calcar replacement prosthesis to give a very good solution for the patients. If you see that the literature, there's some articles talking about arthroplasty is good for patients, hip arthroplasty is good for elderly patients and poor bone and patients with osteoarthritis as a primary solution for intratrochanteric fractures. The big problem in these cases is the stability, and now we can use some elements to avoid the instability, different approach, suture the capsule, use big femoral heads, and the dual mobility, I think, is a very, very good solution for these patients using a prosthesis with a dual mobility cup. Dr. McKee and Dr. Schneider were the first in talking about this solution, and the first coming up with the solution was Gilles Busquets in 1975, and he designed this cup. And in the first generation, they have a press fit fixation, 2 pegs, screws in the domes, alumina coated and porous surface, but the solution was not really good enough, and the results in delamination, wear, and loosening. The modification of this now is using plasma sprays, 3D surfaces to integration, and the lesser size of the cup to prevent psoas irritation, as you see here in this picture. This is a video that you can see here. How is the function of the dual mobility cup? And walking, you can see when in patients, this is a case of arthrosis, but when you use a dual mobility cup, you can have more stability, better range of movement, and it's a very good solution. The patient can do a lot of movement that it's very difficult to do with the normal hip replacement. So I think this is increasing the stability of the prosthesis, and is important in the intertrochanteric fracture because we lose a lot of bone in that in those cases. This is a case when I use dual mobility cup. This is a patient with a fracture of the hip, and then the solution was a hip replacement, but it was unstable because the cup was put too deep. So with the problem of the fracture, we need to do a hip revision, and the first time they use a cemented cup in this cup was very well fixed and difficult to take out, so they use a cemented cup, but the cup was too out of the acetabulum, so the situation was the loosening of the cup. They revised again and it was unstable, and finally we used a dual mobility cup cemented over cement in this position, and we have a very good solution. In conclusion, proximal femur fracture is a challenging public health problem. The relation between the arthroplasty and the intracapsular fracture is well established. The prognosis of intertrochanteric fracture depends on the type of the fracture devices and the age of and the mobility. Hip arthroplasty offers an alternative of these kind of fractures. Patients of advanced age, poor bone quality, and those with existing with arthritis are a very good candidate for this kind of surgery. Thank you very much. I want to invite you to the next Congress in Colombia and the Latin American hip and knee arthroplasty. Thank you very much for your attention.